Hello guys, welcome to Medicomania. We have started this QRS, that is quick revision series, especially for NEET PG aspirants and those who are preparing for FMG exam. We will go through important topics, important points of particular subjects and topic wise uh, quite fastly so that it will help in the revision of all the students preparing for NEET PG and FMG. So today we will go through neonatology, which is from pediatrics specialty. The topic of neonatology, we will cover few important points which are usually asked in exams and which has been asked in previous year exams. So myself, Dr. Himanshu Dave, I am going to give a small lecture on neonatology today. So there are few definitions. We will go through them firstly. The first is perinatal period. Perinatal period is from 22 weeks of gestation to 7 days after birth. These definitions are very important and these can be asked in MCQs, and the options can be confusing, like 22 weeks, 24 weeks or like 28 weeks. So perinatal period is defined as 22 weeks of gestation to 7 days after birth. But keep in mind, this is important, that perinatal mortality rate is calculated from 28th and not from 22 weeks. So perinatal period is from 22 weeks to 7 days after birth, but if you have to calculate perinatal mortality rate, then it is calculated from 28 week to 7 days after birth, or more than 1000 gram. So this is an important point for these two definitions. Next is neonatal period. This all of you know, it's quite easy that first 28 days of life after birth is considered as neonatal period. Infant birth to first year of life, the first year of life is infantile period. And post-term baby, who is termed as post-term baby, the baby who is born after 42 weeks of gestation. 42 completed week of gestation is known as post-term baby. So these are few important definitions. Next is low birth weight. Low birth weight is less than 2.5 kg. We have to remember this, and more than 2.5 is normal weight, especially for Indian population. So less than 2.5 is low birth weight. Very low birth weight is less than 1.5, and extreme low birth weight, that is ELBW, is less than 1 kg. So this is about weight of neonate or newborn. Next is large for gestational age, that is which of the babies are termed as LGA babies, birth weight of more than 90th percentile for that particular sex or gestational age is termed as large for gestational age babies. What 90th percentile here means is, if a baby born at 35th week has a certain weight which is more than 90th percentile for that 35 week of gestation, then that is termed as LGA. Next is preterm. Babies less than 37 weeks. 37 weeks is a normal gestational age. Less than 37 weeks is termed as preterm. 34 to 37 weeks are late preterm. And less than 28 weeks are known as extreme preterm. So questions have been asked plenty of times in past about these definitions. So just go through them quickly, always before appearing for any exam. Next is what is the dose of vitamin K in neonates? Now, the preventive dose of vitamin K which is given to each and every newborn is 1 milligram IM. So 0.5, it is actually 0.5 to 1 mg of vitamin K can be given. And therapeutic dose for HDN. HDN stands for hemolytic disease of newborn. If a patient is diagnosed or suspected case of HDN, then we can give even 1 to 5 milligram of vitamin K. But the usual dose which is given to every newborn is 1 milligram IM. So this is about vitamin K. Next is about the temperature. Hypothermia is defined as axillary temperature of less than 36.5 degrees Celsius is defined as hypothermia. What is cold stress? 36 to 36.4 degrees cold stress. Moderate hypothermia is 32 to 35.9, and severe hypothermia is less than 32. So there is no term like mild hypothermia. The first stage of hypothermia is considered as cold stress, which is 36 to 36.4. Next is moderate hypothermia, and third is severe hypothermia. What is hyperthermia? More than 37.5 degrees Celsius auxiliary temperature is defined as hyperthermia. Now, next, kangaroo mother care. This is a very important topic in neonatology. This is used to prevent hypothermia in preterm or low birth weight babies. Now, what are the 4 components of KMC? It can be asked, these 4 components can be asked in question in form of various options. Like first is skin to skin contact, second is adequate breastfeeding, third is early discharge and ambulatory care, and fourth is support for mother and family for child care. So they can ask which of the following is not a component of Kangaroo mother care. So anything else from these 4 points will be the answer. So just remember these 4 components of KMC. Now who are eligible for KMC? All hemodynamically stable low birth weight babies are eligible for Kangaroo mother care. So next is expanded new Ballard score. Ballard scoring is used to calculate gestational maturity in newborn. This is a scale where scoring system is used to just calculate or suggest gestational maturity in a newborn. So what is the range? So these all are questions has been asked previously in NEET PG or FMG exam or even AIMS. Now question can be asked, what is the use of new Ballard score? So option will be there to calculate gestational maturity in newborn. Next question can be, what is the range of expanded new Ballard score? So it's from -10 to +20. 20 weeks to 44 weeks of gestational age can be calculated from new Ballard scoring. So the score is -10 to +40. Now there are two criteria, neuromuscular and physical criteria. So neuromuscular criteria for maturity includes posture, popliteal angle, square window, arm recoil, scarf sign, and heel to ear. So not a very good mnemonic, but you can remember shape, SHAP, and S2 and P2. So there are two terms with S, like square window and scarf sign, and one with H, that is heel to ear, A, arm recoil, and 2 from P, so posture and popliteal angle. So these are the 6 points for neuromuscular criteria for maturity in expanded new Ballard score. Next is physical criteria for maturity, which includes skin, lanugo, skin texture, lanugo, early ear recoil, plantar crease, breast development, and genitals. So breast nodule and all those things. There is a big table, a big chart for this, and this is not that much required at present, and this is for revision. So just remember these questions has been asked from these points only, that which of the following is not a physical criteria for new Ballard score, and which of the following is not a neuromuscular criteria. So just go through these criteria and remember them. Next is stool color. So initial you would have observed in your neonatology postings or pediatric postings that initial days, for 2 to 3 days mostly, the stool color is black, greenish black. So the reason for this greenish black stool color in early neonatal period is due to which pigment? Biliverdin. And normal yellow color of stool is due to which pigment? Bilirubin. So this is important point to remember. Now next is primitive reflexes. A little idea about primitive reflex. There are few important reflexes elicited in this table: KRAMER'S, MORO, rooting, tonic neck, and parachute. So you have to remember the time of onset of this reflex, when it develops fully, and when it usually disappears. So multiple number of questions can be framed from this table about onset of different reflexes, or when it gets developed fully, and when it disappears. So let's take it one by one. KRAMER'S appears, or onset is at 28 weeks of gestation, it develops fully at 32, and it disappears at 2 to 3 months. What about MORO's? MORO's appears at onset is at 28 to 32 weeks, it fully develops at 37 weeks, and it disappears at 5 to 6 months. Rooting reflex, 32 weeks it begins, it completes by 36 weeks, and around 1 month it disappears. Tonic neck reflex from 35 weeks of gestational age and fully developed by 1 month postnatal age, and it disappears at 4 months. So all the primitive reflexes gets disappeared at around 5 to 6 months of age. Next is parachute. It now just remember these all other reflexes, the onset is during before birth, during the first 37 weeks of gestation, but parachute, it begins after 7 to 8 months of postnatal life, and it develops fully by 10 to 11 months. So in early infantile age, for first 6 months, the parachute reflex is not even initiated. So, and it disappears, it never disappears, it remains throughout the life. So this is an important table for you guys, just go through it. So what is MORO's reflex? MORO's reflex, you know very well how it is elicited. There are two methods, and we may take those in details someday later. Today, just for the revision purpose, what questions are usually asked from MOROs, that when MOROs is absent, in which condition there is asymmetric MOROs, and in which condition there is brisk MORO reflex. So MORO reflex is usually absent in HIE, hypoxic ischemic encephalopathy stage 3, or bilirubin encephalopathy, which is also known as kernicterus. Asymmetric MOROs reflex is seen in clavicle fracture, brachial plexus injury, or hemiparesis. So just to remember, in any orthopedic like injuries, a clavicle fracture or brachial plexus injury, usually the MOROs is asymmetric. For hemiparesis, asymmetric means there is asymmetry between both sides of the body. So in hemiparesis also there is weakness in a particular area, either right or left, so it gives asymmetric MOROs. Third is brisk MOROs is seen in a hypoglycemic child, or it may be physiological sometimes, or in stage 1 of HIE, brisk MORO is seen. In stage 2 of HIE, weak or incomplete MOROs reflex is usually present. So for MOROs, HIE is important because after birth asphyxia, due to asphyxia at the time of birth or after delivery, patient may go into hypoxic ischemic encephalopathy. So you have to remember that in 3 stages, what is the condition of MOROs. So stage 1 HIE, MORO is brisk. Stage 2 HIE, MOROs is weak or incomplete. And stage 3 HIE, MOROs is absent. Next, fencing posture is seen in asymmetric tonic neck reflex. Now question is framed like this: fencing posture is seen in, or which posture is seen in asymmetric tonic neck reflex, that is ATNR. Now what is fencing posture? There is extension on side of face rotation. The face of the baby is rotated, or the neck of the baby is rotated towards one side, and there is extension on that side and flexion on the contralateral arm. So this is the picture showing just a minute. This is the picture showing asymmetric tonic neck reflex. Face has been tilted towards left side, so there is extension of left side, and there is flexion of right arm. So this is asymmetric tonic neck reflex, ATNR. Next, what is this finding? Skin finding. Red papillary lesions. So this is erythema toxicum neonatorum. It's a very common finding seen in nursery or postnatal wards. So these are papillary lesions on an erythematous base seen from 1 to 3 days and may persist up to 1 to 2 weeks. And this question has been asked several times, that if the slide is being prepared from the papillary lesions of erythema toxicum neonatorum, it is abundant in which of the following cell? So these eosinophils are present in the papillary lesions of erythema toxicum neonatorum. So, and what is this? This is Mongolian spot, which is also known as dermal melanocytosis. So this question has been asked in this way also, that what is the another name for dermal melanocytosis? So it is Mongolian spot. These are both physiological conditions, and no intervention is required for these conditions in neonates. Now, two important terms: caput succedaneum and cephalhematoma, and we will also go through this subgaleal hemorrhage. So these are 3 important features which may be seen in neonates. So how to differentiate? First, from location. Location of caput is at the point of contact and can extend across sutures. So this is an important point, that caput can cross sutures. Cephalhematoma usually over parietal bones and do not cross sutures, and subgaleal hemorrhage beneath epicranial aponeurosis may extend to orbits or nape of neck. So next is characteristic: vaguely demarcated, distinct margins initially as it does not cross suture, and firm to fluctuate and undefiled borders are seen in subgaleal hemorrhage. Timing: maximal size and firmness at birth resolves in 48 to 72 hours. So caput is a very normal finding, but cephalhematoma increases after birth for around 12 to 24 hours, and resolution takes time for about 2 to 3 weeks. And subgaleal hematoma is progressive after birth, resolution over 2 to 3 weeks. So volume of blood in caput succedaneum is minimal. It is rarely severe in cephalhematoma, but in subgaleal hemorrhage it can be massive, especially if there is associated coagulopathy. So these are the few differences between these 3 conditions. You can see this is caput succedaneum and this is cephalhematoma. Here the collection is between periosteum and it's above periosteum, and here periosteum is lying here, so the collection is beneath periosteum in cephalhematoma. Now Umbilical cord, are two arteries seen in umbilical cord and one vein. Which vein is left? Left vein is left. These all are the questions asked in previous exams. Single umbilical artery is commonly associated with renal anomalies, and trisomy 18 is also a common finding with single umbilical artery. So this can be asked, for a question can be framed like this: the conditions associated commonly with single umbilical artery, renal anomalies, trisomy 18, both or none. So answer will be both. And show the vein is left, left vein is left, and both the arteries are present in umbilical cord. Now the next topic, which is very common and questions asked quite frequently in exams, is IUGR. First have a look what is ponderal index. Ponderal index is birth weight in grams upon length in centimeter cube and into 100. So gram per centimeter cube into 100 is the ponderal index formula, and there are two types of IUGR: symmetric IUGR and asymmetric IUGR. What is symmetric IUGR? Your length, weight and head circumference is equally affected, but in asymmetric, head circumference is spared, that is brain sparing effect. And early gestational insult leads to symmetric, and asymmetric late insult, brain already developed, so brain sparing effect is there. And ponderal index is more than equal to 2. This all are important questions, that brain sparing is seen in symmetric or asymmetric. Asymmetric insult is only gestation or late gestation. And what is the ponderal index in symmetric or asymmetric IUGR? Or it can be asked in this way, that ponderal index of less than 2 is seen in which conditions? So answer will be asymmetric IUGR. What are the common causes of symmetric IUGR? Any genetic abnormality, chromosomal abnormality, or touch infection? And what can be the cause of asymmetric IUGR? Placental insufficiency or pregnancy-induced hypertension can be the cause of. Because these things usually occurs in late pregnancy, so late insult usually leads to asymmetric IUGR. So these are few points about IUGR. Next is complications of post-mature babies. Post-mature baby usually they pass meconium. So meconium aspiration syndrome can be there, which may lead to PPHN, that is persistent pulmonary hypertension of newborn. Post-mature babies also may lead to hypoglycemia, hypocalcemia, and this question has been asked once, that polycythemia is present, not anemia. In preterm babies, anemia can be seen, but in post-mature babies, polycythemia is usually seen. So in preterm, it's about later finding, not initially. So polycythemia is also seen in IUGR babies, and in post-mature, here we are dealing with the topic complications of post-mature babies. So this question has been asked in previous year NEET, that polycythemia is seen in post-mature babies, not anemia. Next, about KRAMER'S zone, you all might have read in MBBS also, and after that too, that KRAMER'S zone, arbitrary division of body into different segments, and to just make an assessment about the level of jaundice, neonatal jaundice. So there are different dermal zones divided into 5. First is head and face, second is trunk, third is thighs, and fourth is legs and arms, and fifth is hand and palms or sole basically. So icterus usually starts with face, head. So if it's present in face, then level of bilirubin is around 4 to 6 mg/%. If chest and upper abdomen is involved, then it's around 8 to 10. If lower abdomen and thighs are involved, then it's around 12 to 14. If arms and lower legs are involved, it's around 15 to 18. And if palms and soles are involved, it's around 15 to 20. So if palms and soles are involved, it's usually always pathological jaundice, and treatment is definitely required in those conditions. So KRAMER'S zone gives rough idea. So next, what is physiological jaundice and what is pathological jaundice? Physiological jaundice appears after 24 hours. Pathological jaundice usually appears within 24 hours. The rise of bilirubin in 24 hours is less than 5 mg/dl. If bilirubin increases more than 5 per day, or at the rate of 0.2 mg/dl per hour. Clinically not detectable after 14 days. Physiological jaundice usually gets resolved within 14 days, but if it persists after 14 days, it can be pathological, and physiological disappears without treatment, but pathological jaundice need treatment according to the cause of that jaundice. So now the wavelength of phototherapy used in phototherapy light. The light is blue-green. for treatment of neonatal jaundice, and its wavelength is around 460 to 490 nanometer. This question has been asked in AIMS few years back that SN mesoporphyrin, SNMP, is a drug for pathological jaundice of newborn. Usually, till now we have read that only phototherapy is used, but this is some drug in trial, not approved at present. But theoretical question can be asked that SN mesoporphyrin is drug used for pathological jaundice of newborn. It acts by, what is the mechanism of action? It acts by competitive inhibition of conversion of heme to biliverdin by heme oxygenase. So inhibition of conversion of heme, so more bilirubin production will not take place, so jaundice will decrease. Next is what is Brown's-Baby syndrome? Brown's-Baby syndrome is caused by which condition? Which of the following: chloramphenicol, vancomycin, or phototherapy, or all of the above? So answer for this is it's caused by phototherapy. So there are different names you have to remember. Brown's baby is caused by phototherapy, Gray baby syndrome is due to chloramphenicol, and Redman syndrome is due to the use of vancomycin. So these are three named diseases or named condition. Now next is plasma glucose. What is the cutoff for neonatal hypoglycemia? This question has been asked several times. If plasma glucose is less than 45 or if blood glucose is less than 40 mg/%, then the neonate is said to be in hypoglycemic conditions. Not like adult, that less than 70 is known as hypoglycemia. In neonate, the range for hypoglycemia is different. Now, infant of diabetic mothers are at risk of what can happen to infant of diabetic mothers, or what precautions are to be taken for which conditions. So, first, most important is hypoglycemia. Even hypocalcemia can occur. So definition of hypocalcemia, you can remember here in terms, babies less than 8 mg/%, in preterm babies less than 7 mg/%. Hypomagnesemia can occur, macrosomia or large for gestational age babies. TGA, transposition grade arteries, is the most specific CHD. So this question can be asked, which is the most specific CHD for infant of diabetic mother. So TGA is the answer, and neural tube defects can be there in diabetic mother. Next topic is differentiation between gastroschisis and omphalocele. Now this is omphalocele, this is gastroschisis. Omphalocele is covered by usually thin membrane, and it is coming centrally through umbilical ring. And gastroschisis, on the other hand, is lateral to umbilicus, often to the right side, and there is no covering membrane. There can be some fibrous matter, but covering membrane is not there, and the intestines are lying outside. So this is the difference between omphalocele and gastroschisis. Now, tabular form, we can see that site of defect is central umbilical in omphalocele and right paraumbilical in gastroschisis. Sac is always present in omphalocele, it's never present in gastroschisis. Anomalies of rotation and fixation present in both genders. Omphalocele is more common in females and it's equal in the other condition. Associated anomalies. Now this is important point, that other associated congenital anomalies are more frequent in omphalocele, mostly the heart anomalies. So if you see a patient with omphalocele, you have to auscultate it properly to rule out heart anomalies, or even other congenital abnormalities can be there. And associated anomalies are rare in gastroschisis, and intestinal atresia is rare in omphalocele, while it is up to 10% in gastroschisis. So this is differentiation between these two conditions. Many times MCQs has been asked from these conditions. Next is neonatal seizures. This itself is a very long topic, but we are just dealing with few important points for revision purpose, which had been asked in previous exams. That most common cause of term neonatal seizure in term neonate is hypoxic ischemic encephalopathy due to birth asphyxia, and most common cause in preterm is intraventricular hemorrhage. Now, most common type of neonatal seizure is important, subtle seizures. And most common metabolic cause of neonatal seizures is hypoglycemia. Investigation of choice is EEG. Neuroimaging of choice is MRI. And what is the drug of choice for neonatal seizure? It is phenobarbital. So these are important points for neonatal seizures. Now about neonatal sepsis. What is the definition of early onset sepsis? Within first 72 hours of life, and late onset sepsis is after first 72 hours of life. Now commonly in early onset sepsis, pneumonia is seen, and late onset sepsis, it's meningitis. So what are the common organisms for neonatal sepsis? E. coli, Staph aureus, and Klebsiella. Now, what are the components of septic screen in neonates? There are 5 parameters can be used. First is TLC, ANC is absolute neutrophil count, IT ratio is immature to mature neutrophil ratio, micro ESR, and CRP. So just remember, MCQ can be formed that which of the following is not a component of septic screen. So these are the 5 components of septic screen in neonates. Next, what is the gold standard for diagnosis of neonatal sepsis? Gold standard is always blood culture. And next topic, leukocoria or white pupillary reflex in eyes is seen in which conditions in neonate? It may be seen in especially these 4 conditions: congenital cataract, retinoblastoma, retinopathy of prematurity, and persistent hyperplastic primary vitreous. The question which has been asked that it is not seen in which condition, so congenital glaucoma was given in the option. So leukocoria or white pupillary reflex was not seen in congenital glaucoma. Just remember that in which condition it is seen, and if any other option is there, then you can rule out that. Now, when ROP screening is advised, the first screening, it's important, the guideline given by AIMS or even Indian Pediatric Association. So first screen at 32 weeks of postmenstrual age or 4 weeks of postnatal age, whichever is later. So if a baby born at 27 weeks, so or 26 weeks or 27 weeks, so when the screening is to be done, so 27 plus 4 weeks is 31 weeks, but 32 weeks of postmenstrual age, whichever is later, is given in guidelines. So screening has to be done in 32 weeks. Now suppose a baby born at 30 weeks, then when first screening for ROP is to be done? So 32 just comes after 2 weeks, but 30 plus 4 is 34 weeks, which is later. So the first screening is to be done at 34 weeks. Another topic, ICH, intracranial hemorrhage in preterms, is seen in which area? Germinal matrix is the most common site. And which are the common lesions seen in low birth weight or very low birth weight babies? So periventricular leukomalacia is a common finding seen in low birth weight babies. So these are a few important points. Now about necrotizing enterocolitis, most common site of involvement is distal ileum and proximal colon. Now question can be framed and options can be confusing, like proximal ileum or distal colon, or proximal ileum and proximal colon, or distal ileum and distal colon. So you have to choose the most appropriate answer, that is distal ileum and proximal colon. Now most common risk factor for NEC is prematurity, and breast milk protects against NEC. So questions have been asked from these. Now there are, what are the biochemical anomalies seen in abnormalities seen in NEC? Acidosis can be seen as a respiratory or metabolic, and hyponatremia is usually seen in NEC. Next, modified Bell staging. This is used for NEC. Question can be asked, modified Bell staging is used for, so it is used for necrotizing enterocolitis. So this is modified Bell staging, whole table. Just go through it several times so that you may remember it later. There are various stages. 1A, when suspected NEC is there. 1B, also suspected. 2A means NEC is definite but the patient is mildly ill. 2B, definite NEC, moderately ill patient. 3A is advanced stage of NEC, severely ill but the bowels are intact. And 3rd B is advanced severely ill and perforated bowel. So there are various systemic signs, abdominal signs also, and the radiological signs. Question has been asked several times about this, that pneumatosis intestinalis is seen in which stage? So it's seen in stage 2A, and pneumoperitoneum is seen in stage 3B, that is after perforation. And this is about, last column is about treatment. So more treatment is advised in different stages. So just go through these ones. It's not that tough and everything is not to be remembered. Few important points as we have highlighted, these are to be remembered from this table. Now next, this is X-ray showing pneumatosis intestinalis in a patient of NEC. White arrow shows portal venous gas. This is a white arrow, and white arrow is showing portal venous gas, and black arrow, linear or string sign, is seen in black arrow, and the hollow white arrow showed soap bubble sign. So pneumatosis intestinalis X-ray, these 3 signs can be seen, which is depicted in this X-ray. Now, what is Apgar score? Apgar score is usually assessed at 1 minute and 5 minutes after birth, It is not used to guide resuscitation. Mind it, it's not used to guide resuscitation. It's not like that. That first you calculate APGAR score and then you start resuscitation. Resuscitation should be started immediately after birth if required, and APGAR score has to be calculated at 1 minute and 5 minutes. What does it show? It just shows how the baby is responding to resuscitation. Now, what are the components of APGAR score? A stands for appearance, that is skin color. P for pulse, heart rate. G for grimace, reflex, irritability. A for activity and tone, and R for respiration. So there are 0, 1 and 2 points awarded for each of the parameter. So total score can be 10, maximum score can be 10, and minimum score can be 0. So appearance, skin color, if cyanotic all over or central cyanosis is there, then 0 point. If peripheral cyanosis is there, then 1 point, and if patient is pink colored, then 2 points. Now what about pulse or heart rate? If it's 0, because heart rate is absent, then 0, less than 100 is 1, and more than 100 is 2. Grimace, no response to stimulation, 0. If weak cry when stimulated is 1, and when good cry when stimulated is 2. Activity, floppy child 0 point, some flexion 1 point, and good flexion and resisting extension is 2 point. And what about respiration? If the child is apneic, no respiratory effort, then 0 point. If slow or regular breathing is there, then 1 point. If strong breathing is there, then 2 points, so strong cry. So next, what is this? This is self-inflating bag and mask or AMBU bag. There are various components of this AMBU bag. This is face mask. This is pop-off wall. It opens and it peep wall is there. It adjusts peep, that is positive and expiratory pressure. This is expiratory wall. This whole component is known as self-inflating bag. This is the portion where oxygen inlet and tubing is used from the source of oxygen. And air inlet and pressure release valves. There is a reservoir bag connected at the end, and air inlet one-way valve and oxygen reservoir socket is there. So diagrammatic question can be asked about the parts of self-inflating mask, bag and mask. Now, what is the use of this self-inflating bag and mask or AMBU bag? It is used for giving positive pressure ventilation during neonatal resuscitation, and this is important point. Absolute contraindication for using this bag and mask is congenital diaphragmatic hernia. If congenital diaphragmatic hernia is suspected and or diagnosed antenatally, then using the bag and mask ventilation is absolute contraindication. Now, during neonatal resuscitation, suctioning of mouth is to be done before nose. M comes before N in alphabet, so first mouth is to be suctioned and then nose. Why this is to be done? Because if you first stimulate the nose, then due to reflex activity, the baby might aspirate all the content which is present in mouth. So first mouth is to be suctioned and then nose. Now next is what is the compression to ventilation ratio in neonatal resuscitation? Compression to ventilation should be 3:1, that is 90 compressions and 30 breaths in 1 minute time. 3:1 you should remember. Now what is exit? Exit stands for ex utero intrapartum treatment procedure. So ex utero intrapartum treatment procedure, when airway is secured before the infant is separated from placenta, then this is known as exit. That is ex utero intrapartum treatment procedure. Now initial feeding in low birth weight babies. At what gestational age, how to initiate feeding in babies? If it's less than 28 weeks, no suction activity has been developed, or no coordinated suction or no strong suction efforts are there, so IV fluid is to be given. 28 to, and even intestinal peristalsis, intestinal movements are also not coordinated, so IV fluids. 28 to 31 weeks of gestation, OG feeding, orogastric or narogastric feeding can be done with occasional spoon or palliative feeding if the patient is having good sucking abilities or good coordination. 32 to 34 weeks, usually we start with spoon, palliative or cup feeding, and more than 34 weeks we give breastfeeding. So questions has been asked several times. Now what are the few benign or physiological findings in newborn? Erythema toxicum neonatorum, Mongolian spots, pustular melanosis, sebaceous gland hyperplasia, melia, Epstein pearls which are seen on hard pellet, cutis marmorata due to cold stress, vaginal bleeding in female child, breast enlargement in both sexes can be seen due to maternal hormones, and conjunctival hemorrhage, skin peeling. These are all benign or physiological findings in newborn for which no treatment is usually required. So the questions have been asked several times. Now, teratogenic drug and poor defects with the use of those drugs: lithium may cause Epstein anomaly, topiramate may cause cleft lip, Valproate usually causes NTDs or facial cardiac defects and coarctation of aorta or VSD. Progesterone causes masculinization of female fetus. And vitamin D causes supravalvular aortic stenosis. Warfarin may cause coagulopathies or hypoplasia of nose. Statins usually causes vectoral anomalies. Vectoral anomalies stands for vertebral, anal, cardiac, tracheoesophageal fistula, renal, arterial, and limb defects. So vectoral stands for all these. Now phenytoin may cause ASD, VSD, PDA, or coarctation. Carbimazole or methimazole can cause coronal atresia or aplasia cutis. Aplasia cutis, there can be an image of a neonate with some skin normality on his scalp, which is usually known as aplasia cutis. There's lack of formation of proper dermal segments in scalp. This can be caused by carbimazole or methimazole, and alcohol can cause ASD, VSD, or even microcephaly. So thank you very much. This was a quick recap, quick revision series for neonatology. Soon we will present another topic from the pediatrics or any other subject. Kindly give your feedback and share the link of our channel or this video with your friends or colleagues preparing for NEET PG or FMG or even your MBBS friends. Thank you very much. This is the handle for our YouTube channel, that is @